When you're a Nigerian immigrant who went from being a safety net hospital patient to being a hospital president, how do you think about health equity? I'm Andy Reynolds. Today on Quality Matters, we get answers to that question from Tosan Boyo, president of Sutter Health East Bay Market in California. Tosan previews his keynote remarks on health equity at the NCQA Health Innovation Summit, November 1st in Nashville. Tosan Boyo, welcome to Quality Matters.
Thank you for having me again.
We should tell our audience, you and I go back a ways. You were a hit speaker at NCQA's Quality Talks in spring 2022, and you are returning to an even bigger NCQA stage at the 2024 Health Innovation Summit. You are a panelist for a keynote discussion about health equity.
I'm excited to be back.
Something that fascinates me, Tosan, is your background. You immigrated from Nigeria, and you've had some fascinating experiences. How or why did you begin working in healthcare?
I was born and raised in Nigeria, and I was raised by two health workers. The moment I knew I wanted to devote my life to healthcare was June 12th, 1993. Nigeria was going through its first democratic election in decades. And the person who was going to become president was disappeared by the government, never to be seen again. Riots broke out and there was violence everywhere. And my family managed a hospital. And I'll never forget my parents making it clear to patients who were victims, and in some cases perpetrators of violence, they could not bring their violence into the hospital. I have this vivid memory of people leaving their weapons outside and being allowed to come into the hospital if they agreed to no violence. So for me, from that moment, hospitals have been sacred spaces. I have a second pivotal moment coming to America. This is a vivid memory of getting hit by a car, talking to another immigrant who recommended going to a safety net hospital because safety net hospitals were known for providing phenomenal care for immigrants, underinsured. That was a pivotal moment, introducing me to the health system in the U.S. I always wanted to work for healthcare institutions that prioritize vulnerable populations. And those moments shaped my devotion to healthcare. Healthcare is embedded in me. I can't imagine doing anything else with my life.
Those pivotal moments, witnessing people leaving their weapons at the door to enter the safe space of the hospital in Nigeria, and then your experience in a U.S. safety net hospital after you got hit by a car. How do those experiences play out in your work in health equity now?
It's a reminder that when patients present to hospitals, they're in pain and they're in fear. That's number one. Number two, it informed why I believe that when we take care of patients and support communities, we want to understand their story. The difference between equality and equity is equality is stating, hey, everyone should be treated the same. But if you treat everyone the same, some communities are going to be left behind. If English is not your first language, if you have to catch multiple buses to get to the hospital, if your child gets their best meals when they are at school, those nuances influence the stories of the people we take care of. So for me, those moments that fueled my desire to embed myself in healthcare remind me that hospitals have a sacred duty to care for all, and we need to do everything in our power to understand the patient's story so that we can tailor their care to their needs based on race, ethnicity, language, socioeconomic status, sexual orientation, and gender identity. When we put in effort to learn those lenses, we ensure patients live the healthiest lives possible.
Not many people go from being a patient at a safety net hospital to being a hospital president. What do you wish people at either end of that spectrum understood about each other?
Andy, these questions. Well, here's what I'll say. I wish executives understood that, and actually, I'll say, I wish the workforce understood that most patients who are on Medicaid, who are underinsured, uninsured, are doing their best with what they have. Understanding that changes the way we show up, because when you are struggling in society, in many cases, healthcare does not become a priority. When patients who are vulnerable make time to come for care requires adjusting who's going to cover for their children, what shift are they going to have to miss from work, the time to get healthcare and waiting for healthcare, how does it impact their whole day? We want to make it convenient so they don't have to sacrifice childcare or hourly wage to show up. That's number one. Number two, by caring for our most vulnerable, we are making sure we don't lose touch from the front lines of the workforce, who in many cases come from that population. The job I'm in at Sutter Health East Bay, I live in this community. Many of the folks in our staff and physician workforce were born in the hospitals that we are working in. I've chosen to work in institutions that prioritize Medicaid. Every institution I've worked in had the largest Medicaid population in that region. It's such a meaningful role to feel like I'm adding value, and I want our patients to know that for us, it's not just a job. It's a calling. This is where we are. The two places people never want to be are prison and hospitals. If you're a health worker, you are spending at least 40% of your life in that place, right? That says a lot about us in the healthcare workforce. And I want our communities to understand that.
You were in charge of San Francisco Public Hospital's COVID response. Looking back on that experience, what did you learn about U.S. healthcare, and in particular, what did you learn about health equity?
The biggest gap in the beginning was realizing how siloed public health systems were from private health systems, and how challenging it was to share information and operate in unison. A big lesson was we need to do a better job to ensure that we have not just relationships with public health departments, but we are working in unison to care for a community. The number one thing I have taken from that role in how do we proactively ensure no community is left behind. Now I want to ensure that no matter what service we are delivering, no portion of patients based on race, ethnicity, socioeconomic status, or language experience higher morbidity and mortality. I think about that every day. It's one of the reasons why I believe in NCQA is how do we ensure we're constantly aiming for high quality outcomes on the delivery side and on the payer side.
You mentioned that you think about these topics every day. How has that thinking evolved?
Well, I mean, Andy, you always ask the great questions. I would say one thing that's different for me, healthcare is beyond the hospital and clinic walls. I think about that more now than I did, because your health doesn't stop when you're discharged. Your health doesn't stop when your appointment ends. There is work that happens within the hospitals and clinics, and there has to be work that happens in the community. What are we doing to establish trust within the community? What are we doing to ensure when patients are discharged from the hospital, they're staying healthy and have resources available? What are we doing to strengthen wraparound services after they leave us? The pandemic highlighted how trust was fragile between healthcare institutions and communities. 4 years later, I'm responsible for 6 hospitals across 3 counties, 20 ambulatory centers, 10,000 staff and physicians caring for almost 600,000 patients. We have to maximize access and build community relationships. That has been a really big shift for me. I think about that more now than I did.
You mentioned trust. How do you think institutions build trust, especially when it is low or when trust has taken a hit?
Yeah. I'm laughing because this is a great question. The first thing is, how do we show up in communities? When communities and patients sense inconsistency, that can make trust fragile. We have to be consistent, present, proactive in communities, moving away from paternalism. How do we partner to ensure the best outcome for you as a patient? And how do we partner with community-based organizations to ensure every person has the best care possible when they're in the facility, but then being able to maintain health when they leave? It changes how we show up. Lastly, how well are we reflecting the communities we take care of? If the workforce does not look like the community, that's a signal. If the leadership does not look like the community, that's another signal. We all benefit when we reflect the communities we take care of, because that sends a message.
At your 2022 Quality Talk presentation, you made the point that equity work verifies quality work. I'm interested in the verb verify. How does equity work verify quality work?
Health equity gives us tools to validate we are living up to the thesis that motivates us to come to work every morning. Fundamentally, delivering high quality outcomes is always the priority. With that thesis being a foundation, how are we ensuring that every patient is achieving the high quality outcome? We verify that by saying, let's stratify your outcome metrics by race and ensure that race is not a factor, that one population is not getting the same high quality outcome. Let's do it by language and ensure that language is not a barrier to access and not a barrier to following the instructions that you get from a physician. Let's verify by zip code to understand socioeconomic status. How are we ensuring that regardless of zip code, you are getting the best care? These are different ways we can verify we are living up to the priority to deliver high quality outcomes.
You also mentioned in your 2022 Quality Talks presentation that transparency about results is important, including transparency to your own staff. Can you tell us about that, please?
You measure what is important to you. That's one piece. The second piece is, are you being transparent about what you're measuring so that everyone can see, are we making progress? What can we do better? It's one thing to be transparent, it's another to have the conversation of, hey, this is what the data is telling us about health equity. Anytime we are trying to improve a quality outcome, we need to engage in those conversations with the data. Because we don't like the data doesn't mean that we should hide it. More than anything, we need to look at data that is not going well as a flare that says, hey, what can we do more of, less of, or differently?
You mentioned data as the flare of what can we improve or do differently. How do you keep data from being something your own staff fears?
It always comes down to why. Why are we measuring what we are measuring? Right now, there's all this backlash against DEI. Like, this is becoming a major thing across the US. Everyone in healthcare believes we do not want any community to be suffering more. We want all of our patients to thrive pre and post discharge. That is something that unites all of us in healthcare, regardless of whatever backlash is happening. So if that is fundamentally the why, and healthcare is a calling, this is how we get everyone to understand why we should not be afraid of data. Prioritizing data, stratifying it, and being transparent is how we are walking the talk. We can separate ourselves from the backlash by saying we want none of our patients to suffer more than anyone else. We want none of our patients getting sicker or dying more than anyone else. The why is fundamental to move away from blame and shame and saying we have this duty to ensure no one is left behind.
What do you think is going well, or what's the strong point of health equity work these days? And what do you think is the most undiscovered new thing that people who care about equity should know about?
What's going well is we've reached a zenith where health equity is being embedded across healthcare in establishing metrics, policies. I believe the next frontier is how does delivery systems partner with payers and possibly with life sciences to see how can all three verticals impact health equity together. Payers looking at what happens upstream, healthcare looking at what's happening downstream, and life sciences thinking about the future. That is an untapped area that I'm excited about exploring.
Tosan's observations resonate with many people at NCQA.
Hi, I'm Rachel Harrington. I'm AVP for Health Equity Sciences at NCQA. As somebody working in this space, it's motivating to see equity being integrated throughout healthcare. For a long time, health equity is treated as niche, and it's not niche. Equity has been part of quality for at least 22 years. Institute of Medicine, Crossing the Quality Chasm, 6 domains of healthcare quality, equity was in there as one of the 6. So it's been explicit, but even implicitly, if you think about Plan, Do, Study, Act, quality improvement is identifying gaps in care, root cause analysis, technical things like fishbone diagrams, all those ways of understanding where quality is breaking down so we can improve outcomes. Equity is part of that. Equity is subgroup analysis. Equity is root cause analysis. Equity is understanding how people are accessing or not accessing care. These are all things we've been doing for decades. It's just taking different pieces of information outside the walls of the healthcare system to say, does somebody have electricity to keep their refrigerator on, to keep their insulin? That's what quality is good at. It's just making sure we're building this understanding into all of the processes we have.
Rachel, can you give me some examples? Where do you see the most energy and momentum?
Many activities are pushing the level of care and intention forward. States have been a forerunner in implementing equity expectations. We're at 16 states mandating NCQA's health equity accreditation, and that's just the tip of the state iceberg. CMS has also been a leader. They centered equity in the Universal Foundation for Measurement and are building structural requirements like the new birthing friendly hospital designation. We're also seeing in the private space, employers are working with insurers and other partners to address unmet social needs of their employees and their employees' families. So this is becoming the new norm. It's just on us to make sure we're continuing to build on this momentum. So as Tosan said, no person is getting sicker or dying more than any other, and everyone has the opportunity to achieve their best possible health.
Thanks, Rachel. We will link in the show notes to some of those publications and policies that you mentioned. Tosan, you're part of one of the main sessions at NCQA's Health Innovation Summit on Friday, November 1st. That is a panel discussion titled Health Equity Across the Care Continuum. What can people expect from you at that major presentation?
They should expect my focus to be how we ensure no community is left behind. How do we ensure there is no disparity in a patient's experience as they transition across the care continuum? How do we ensure race, language, ethnicity, and socioeconomic status are not barriers while care transitions occur? And how do we make it as seamless as possible for patients through every walk of life?
Let's leave it there. Tosan Boyo, president of Sutter Health East Bay Market. It's good to see you again. Thank you for joining us on Quality Matters, and we'll look forward to seeing you at your panel discussion November 1st at the Health Innovation Summit in Nashville.
All right, take care. Bye.
A quick programming note. The next episode of Quality Matters will be available November 21st. Thank you for listening to Quality Matters. You can always learn more at ncqa.org, and be sure to subscribe to Quality Matters wherever you get your podcasts. We'll see you next time.